You guys can see my screen.
Yeah, we can see.
Okay, so today is gonna be about hemostasis. So we covered the formation of platelets as part of the blood components. So the importance of platelets is in hemostasis. So hemostasis basically means it's stopping bleeding. So it is involved in the role of platelets, where the role is just to avoid us from bleeding out when we have an injury. So there are very many things involved. Uh, the first thing is usually there's injury, of course, the first thing. The second thing is platelets, and the other things are the clotting factors. So the clotting factors go from, they're given Roman numbers, they go from 1 to 12. You don't really have to know their names. Uh, I'll show you an easy way of like trying of remembering them. Not their names, but just their relevance in terms of the numbers. So they go to 13. So let's use this summary. So when you have an injury, uh okay, the injury is what triggers the coagulation cascade. So before we go, let's first finish hemostasis. So what happens is that once you get an injury, there are 3 phases that are initiated. The first stage is primary hemostasis. So primary hemostasis involves 3 steps. So it triggers, the injury triggers vasoconstriction. So that is the most immediate thing that happens, where the body tries to limit the amount of blood going to that area so that not much of it is lost. So vasoconstriction is initiated. The next is platelet plug formation. So the blood that is, even if it's limited, see, there's still blood moving to that place. So the blood, of course, will contain our platelets. So damage to the blood vessel exposes endothelial collagen, subendothelial collagen. That's important to note. And then the second thing that you need to note is the platelets on their surface, they have something called the von Willebrand factor on their surface. So when you get the injury, the platelets migrate as blood flows to the injured site. And now hemostasis is initiated, where like a sandwich is formed. The von Willebrand factor is what acts as a glue that binds, it's on the platelets. It now binds to the collagen. So it aids the platelets in binding to the collagen. So that is the first step of primary hemostasis. It helps to like start plugging the leak. So the next step, once they attach, so these are the platelet aggregation. Serotonin is released by the platelets. This is what causes the vasoconstriction to reduce the blood flow. Then ADP, calcium, and thromboxane. Calcium is a very important factor. It is implicated in majority of the steps in the clotting cascade. And then thromboxane is also a vasoconstrictor, and it promotes the aggregation of platelets. The next thing is secondary hemostasis. Now it starts. This is now the coagulation cascade. So the coagulation cascade has 2 pathways. Sorry, 3. There's the intrinsic pathway, the extrinsic one. Then the both of them, they come and meet at the common pathway. It's like a Y shape. So let me try to zoom into this photo. Is it visible vizuri? So the coagulation, you see this
Yeah, it's
on the
visible. I
left, we
was
have
just
the
getting to
intrinsic part. The intrinsic one is the longer one. Then the extrinsic one is the shorter one. Then they all meet at the common pathway. So for the we start with the common pathway, just hapa juu. The target is factor 10. So both pathways, intrinsic and extrinsic, seek to activate factor 10. First, keep that in mind. So at the extrinsic pathway, we start with the extrinsic. The extrinsic one is the shorter one. It only involves factor 7. So tissue injury at the vascular site leads to release of tissue factor, also called thromboplastin. So thromboplastin activates factor 7 to factor 7A. So 7A is just the activated form of factor 7. Then this factor 7A is what activates factor 10 to 10A. So where they meet. On this other side, it's the same thing. They're all trying to come activate factor 10. So it starts as a countdown. Factor 12 activates factor 12 is activated by the collagen. Factor 12A. 12A activates 11 to 11A. So it's a countdown. Once 12 is activated, it activates 11. So since there's no 10, it activates 9 to 9A. 9A activates 8 to 8A, like that. So it starts from 12, 11, 9, 8. So 8A is now what meets here, 7A, to activate factor 10. Are we together? Guys, are we together?
Yeah. Nah, we are seeing this down there. Yeah, well, yeah. So, yeah, nice.
So this side we have 12, 11, 9, 8. This side we only have 7. And the initial activator for intrinsic is collagen. For extrinsic is tissue factor. Okay. So once we now have our things here, on this side we have factor 8A. On the other side, our factor 7A. And calcium, since I told you it's also an important factor. Now factor 10 is activated to 10A. Once factor 10 is activated to factor 10A, factor 5 is a cofactor. It's not really a factor in itself, it's a cofactor. So factor 10A together with cofactor 5 activates prothrombin to thrombin. Now this is now the clotting. And then thrombin, of course, activates fibrinogen to fibrin. And then fibrin is it has its effect for cross-linking and forming the fibers that lead to the plugging of the leak. That's basically it regarding the clotting cascade. So this is what I was saying. The intrinsic and extrinsic, they both come to find the common pathway. Common pathway leads to the formation of a fibrous formation. So this is basically it's like a repeat. See what I was saying. Tissue injury exposes collagen. So collagen is important for the primary hemostasis, right? It helps bind the platelets and also in the intrinsic pathway by activating factor 12 to 12A. And then on the other side, now the extrinsic pathway is your tissue factor that activates factor 7. So still a bit. Yeah, so both pathways eventually lead to activation of factor 10. And then factor 10 combines with the other factors like factor 5 and calcium to form prothrombin activator complex. The prothrombin activator complex is what converts prothrombin to thrombin. Then thrombin changes fibrinogen to fibrin. And then the fibrin mesh is formed, which seals the hole. So the regulation, since the body is homeostatic, it also has its way of regulating all these effects. So the clotting factors are the major regulators of clotting. So the presence or absence or their quantities. Then the liver, of course, the clotting factors are manufactured in the liver. So patients with liver problems usually also have a tendency of getting clotting problems. Then anticoagulants in blood, like we'll just get to them. The intrinsic heparin, coagulation, localization. So what localizes coagulation? The first thing you need to know is that vasoconstriction that we mentioned. It helps to localize the coagulation. Then the phospholipids on the exposed surface after the damage helps also to localize coagulation, because that's the only place where the platelets will be activated. Anticoagulants such as tissue factor inhibitor is an anticoagulant that is usually present. It is also important in the regulation of clotting. Thrombomodulin, protein CNS, and antithrombin are also regulators of clotting. So this one is still done. So since the formation of the clot is not something permanent, so once the vascular wall is repaired, the fibric mesh has to be like destroyed so that now a state of normalcy can be reachieved. So the first step is blocking of the coagulation cascade. So this can be done by thrombomodulin. So this is a factor that blocks the thrombin from activating fibrinogen. So that stops the deposition of fibrin. Then once you've stopped the coagulation cascade, you can now, the body starts breaking down the fibrous clot. So plasminogen is an enzyme that is activated to plasmin. And then plasmin is what degrades the fibrin clot. So plasminogen is activated by endothelial cells, which the endothelial cells release a factor called tissue plasminogen activator. And then factor 12 also activates plasminogen. And then thrombin also activates plasminogen. Thrombin is involved in the negative feedback of the clotting cascade at different stages. So we have that stage where it activates fibrinogen. Now we can see that it also activates plasminogen. So it has like two effects that depending on at what level the body is at, it has different effects at different points. So once the fibrous clot is broken down, that's when it leads to the formation of fibrin degradation products. So these ones are clinically important because they can be measured in blood, and then this can help diagnose stuff like internal bleeding at one point or another, because they will appear when the blood is tested. So yeah, this is just what hemostasis involves. The first step is primary hemostasis. The second one is secondary hemostasis. And then once the body heals, fibrinolysis, breaking down of the clot, as you said. So these are just the cells involved in hemostasis. We have the endothelial cells, the simple squamous epithelia. They line the blood vessels. So the importance we know, they form a barrier. They also mediate inflammation by enabling the movement of leukocytes. Remember, Jana, we said there are two types of leukocytes. There's the pooling and the circulating. So the pooling are usually located around the endothelial cells. So yeah, it's a membrane. So it also is involved in fluid distribution by changing the permeability. Hemostasis is another important. We've seen when it's broken, the collagen has its factor for activating platelets, tissue factor also is released by the cells. Okay. Then there's also the process of angiogenesis, which is formation of new vessels or repair. This one we did. So just like different diagrams, whichever you find easy is what you can use to like study the cascade. So we can go to the disorders of hemostasis. So the first one, I didn't want to use the book. Let me try using Orata. This one oversimplifies the stuff I'm missing. Another document. I hope it's visible.
Yeah.
Yes, it is.
So platelet production we did. So regulators of platelet formation, we have an enzyme called thrombopoietin that is produced in the liver. You remember how in the red blood cells we had erythropoietin provided by the kit. For platelets, we have thrombopoietin. It's produced by the liver. It is what regulates platelet platelet count is usually 250 stent per liter. So between 150 to 400, that's the range, but the average is 250. I have mentioned this, the von Willebrand factor is what helps the platelets bind to each other and also bind to the collagen. It induces a conformational change in the platelets, making them just get for lack I can just explain it like spikes. It makes them get spikes that enable them to just bind to each other. So when we go to tests of hemostatic function, defective hemostasis with abnormal bleeding may be due to a vascular disorder, or it can be due to thrombocytopenia, that's reduction of platelets, or a disorder of platelet function, or defective blood coagulation. So when you're testing when someone presents with problems with their clotting, some of the simple tests you'll do, of course, you'll do a blood count to help you identify whether thrombocytopenia is present. Blood film will also be important to just observe the platelets and see whether they're morphologically normal. And then also their count, are they enough for thrombocytopenia? So there are also screening tests. Some of these tests are specific for different pathways, the pathways we mentioned, whether it's the intrinsic one or the extrinsic one. So some of these tests include prothrombin time. So prothrombin time is basically the time taken for plasma to clot after the addition of tissue factor. So factor 3 is added to blood, and then tissue factor is factor 3. It's added to blood, the one that you've extracted, and then you time how long it takes for coagulation to occur, for a clot to occur. So if it's tissue factor you're adding, you remember tissue factor was the activator for the extrinsic pathway. So that means PT, prothrombin time, is specific for the extrinsic pathway. Then the other test is APTT, which is activated partial thromboplastin time. So this one refers to time taken for plasma to clot after the addition of phospholipids. So phospholipids they're related to collagen. The activators for the intrinsic pathway. So APTT is specific for analyzing any issues with the intrinsic pathway. You can also have your bleeding time. It's not reliable. It's not a reliable assessment of platelet function. So you just induce an injury and see how long it takes for bleeding to stop. So the normal time taken is 3 to 8 minutes. Tests of platelet function. So these are upcoming methods that came about, like flow cytometry, to just identify what defects are there in your blood components that affect hemostasis. Like you have the PFA 100 test. So I don't think these are very important. You go to the other document. So for the tests, the important things to note are the things I've said that PT is specific for extrinsic pathway. APTT is specific for intrinsic. PT extrinsic, APTT intrinsic. But now, I was reading and I found that in some conditions, you can get a normal level of PT and APTT, but the patient is still presenting with clotting disorders. So that can be due to liver disease, leading to the decrease in the production of the clotting factors, or a vitamin K deficiency, leading to vitamin K is important for platelet formation. So that can also cause clotting disorders that will present with PT and APTT that are abnormal. Oh, sorry, not normal, abnormal. If both of them are abnormal. So it helps to show that the problems are both in the intrinsic and extrinsic pathways, meaning that it's the cofactors themselves that are maybe not there or are not there in adequate proportions, or they have issues. They're not functioning the way they should. So when you go to the problems that involve platelets, the first one is thrombocytopenia. So thrombocytopenia can be as a result of sample integrity, whether your phlebotomy was done well or not, or it can be due to decreased production. Maybe that indicates a problem in the bone marrow. See, the bone marrow is the site for production of platelets. So thrombocytopenia can be due to decreased production. So it's worth noting that, like patients who are undergoing chemotherapy, you remember some of the side effects for chemotherapy drugs included pancytopenia. That can mean even the platelet count can go low and can therefore lead to bleeding disorders for such patients. So it can also be as a side effect of treatment. So thrombocytopenia can also be due to altered distribution of platelets. So the normal spleen holds like a third of the platelet volume. The other 2/3 are the ones that are usually in circulation. So several hematological conditions can lead to an enlarged spleen. So enlargement of the spleen can increase its carrying capacity, meaning blood will pool in the spleen, and a large proportion of blood will pool in the spleen, and thus there will be a reduction of the circulating platelets. Or an additional scenario in which platelet distribution is altered is in massive transfusion. So so once the total blood volume has been replaced with 2 or 3 volume exchanges, the platelet and coagulation factors can become diluted. So this can lead to a transient thrombocytopenia. That's the one for massive transfusion. Thrombocytopenia can also be due to immune effects of specific drugs or antibody formation. So quinines, NSAIDs, sulfonamides, and diuretics are particularly relevant. So we know NSAIDs, stuff like aspirin. That's why it is indicated for like the junior aspirin. It reduces platelet aggregation. So some of these drugs have such kinds of effects that affect the clotting cascade. So yeah, this effect of drugs can be twofold. where the drug can cause anti-drug antibody formation that binds to a glycoprotein on the platelet. And then this causes the platelet to be removed by the reticular endothelial system. So it's flagged as an antigen. And then the second mechanism is where the drug can combine with a larger carrier protein to form an antigen. And then the antigen triggers an antibody response and subsequent platelet destruction in the spleen. So these are these are drugs that can cause thrombocytopenia. So we've seen it's NSAIDs, quinines, sulfonamides, and some diuretics. The other thing that can cause thrombocytopenia is consumption of platelets. So these are the conditions that she was mentioning, like ITP and TTP. So yeah, they're discussed deeply here. So this one, idiopathic thrombocytopenic purpura is a result of immune destruction of platelets. So the antibody is usually an autoantibody that is directed against specific glycoproteins that are present on the platelets, leading to their destruction. So it can be chronic or acute. Most patients with acute ITP are children who are between 2 and 6 who have just recovered from a viral illness. This condition can cause the platelet count to drop very low. So, a platelet count of as low as 20 can be very dangerous. So you can even have the child presenting with spontaneous nosebleeds, petechiae. Yeah, just presentations that show that there's a problem with the clotting. It's not happening. So treatment involves, you can give anti-D immunoglobulins or IVIG. This is IG immunoglobulin, which I am not sure which one, or another one called Winro. A splenectomy can also be done, or platelet transfusion. These are the treatments for the acute kind of ITP. So chronic ITP, so you said ITP of acute kind is for children. So the chronic type is present in people who are much older, so between 20 and 50 years of age. And the platelet count does not usually present as very, very low, not as low as for the acute kind, but still quite low because the range is around 150 to 400. So it's low, but not too low. So for this patient, an IgG antibody is produced that coats the platelets. So this IgG antibody makes these platelets to be destroyed by the spleen. And it is a chronic process, so it happens over a prolonged period of time. So that's what causes the reduction of the platelet count. So for this one, the chronic ITP is treated with prednisone to suppress the body's immune response. The suppression of the immune response increases the platelet count and decreases any hemorrhagic episodes. So if prednisone is given and it does not work, you can give anti-CD20, rituximab, which also works. Splenectomy is the next logical option because once you remove the spleen, there will not be a lot of destruction of the platelets. So they're still available to provide the effects. So for patients with viral conditions like HIV, hepatitis C, or even H. pylori, they show thrombocytopenia at some point during their disease. I think there's something called HIV-induced bone marrow failure. That is a condition that affects it. When patients have chronic HIV, maybe it's untreated, it gets to levels where it affects the bone marrow, and then it becomes difficult for the bone marrow to make some of these cells, and the platelets are also implicated. So there will not be enough platelets formed, so thrombocytopenia will definitely occur for these patients. So this is just how to differentiate from acute ITP and chronic ITP. So acute is in young children, but chronic is in adults. Acute usually follows previous viral infection. There's history of an infection, but for chronic, there's usually no history of infection. Then there's, in terms of the platelet count, we said for acute, the platelet count is usually very low, less than 20, but for the chronic kind, it's between 30 to 80 or to 60, or just around there. So the duration of during diagnosis, the symptoms for acute, since it's acute, it's just minimally within weeks. But since the other one is chronic, it takes months to years. The patient should have a history of months to years. For acute therapy, there's really nothing you can do. You can just try to help the child, maybe do a splenectomy, give you platelets. But for the chronic type, since it's antibody initiated, you can suppress the body's response by giving steroids, or you can do a splenectomy to just avoid the destruction of the platelets. The other condition is TTP, thrombotic thrombocytopenic purpura. So it is a devastating disorder and is very acute and very unpredictable. That is more prevalent in women than in men. So it can occur in women postpartum or near delivery, in those who have suffered from other immune disorders like SLE, or those with previous viral infections or gastric carcinomas. Platelet counts are similar to those of acute ITP, so they are less than 20. But the other tests, like the ones we talked about, PT and APTT, they're usually within reference range. So all the factors are present. You can't really tell whether the problem is in the intrinsic or extrinsic pathway. You can't tell, it's just a problem with the platelets themselves. So platelet thrombi are dispersed throughout the arterioles and capillaries subsequent to the accumulation of large von Willebrand multimers made by the endothelial cells and platelets. So the reason for this accumulation of the multimers of von Willebrand factor is a deficiency of this one, ADAMTS13, which is a large metalloprotease. It is usually responsible for the breaking down of the von Willebrand factor from large multimers into smaller proteins. So absence of this ADAMTS13 leads to now formation of large multimers of von Willebrand instead of having it in small, like monomers or dimers. So they exist as multimers, which now increases the binding sites. Besides, von Willebrand factor acts like the glue when there is vascular injury. It's what helps the platelets bind to each other and bind to the collagen on the vascular endothelial wall. So the multimers will increase the surface area, meaning there will be more binding of the platelets to each other. So you will get schistocytes are also seen in the peripheral smear, and they're directly related to shear stress as fragments of red blood cells are removed once they try to sweep past the thrombi. So there will be, the aggregates of platelets will reduce the, what's it called? Will just make the vasculature very narrow, So there's going to be a lot of shear stress on the other components of blood, so they tend to rupture. So yeah, you will get schistiocytes in the blood once you do a PBF. So yeah, that can explain anemia that is seen with patients who have TTP because of the hemolysis. So this is just describing that anemia. So treatment is difficult because you can see even here, like patients present as a dilemma for the physicians. So it's difficult to treat this disease, but corticosteroids in conjunction with a plasma exchange are usually helpful. So the corticosteroids, as we know, they will reduce the immunity, the body's immune response, meaning less platelets will be destroyed. Yeah. Then plasma exchange to just introduce new components that are of normal nature. The von Willebrand factor is not going to be in multimers now in this new plasma. So it's just like first aid to help the body continue running smoothly. Of course, few hospitals provide plasma exchange. So yeah, treatment for this condition has been a problem, but okay, technology is increasing. So hopefully there are better ways of treatment. The next condition is HUS, which is hemolytic uremic syndrome. So this one is also another condition that's common in children. It mimics TTP, but the exception is that renal damage is more severe. So this one is due to the Shigella toxin that is produced by the bacteria called E. coli. So most of these patients you'll find they present to hospital with a history of maybe gastric distress where they had been colonized by E. coli, maybe it wasn't treated. The E. coli managed to make its way into the blood, and then it gets deposited somewhere in the kidneys. And then once it's deposited there, it continues to produce the Shiga toxin, which now causes, it breaks down the kidneys. So mostly by that, the children present with bloody diarrhea and vomiting, thrombocytopenia, and renal failure. So in children, the illness is self-limiting. So once the toxin is eliminated, so of course, the treatment will have been achieved. So the body goes back to a state of normalcy. So this is just differentiating HUS and TTP. So they have similar platelet counts. The patients present with similar platelet counts of less than 20,000. But now in HUS, the main organ affected is the kidney. But in TTP, the kidney is there, but there will also be neurological manifestations. HUS is for children, and then TTP is present in adults, more in females than in males. Symptoms are similar. You will have fever, but now for HUS, there will be a lot of bloody diarrhea. The feces can actually be red, completely red. Then for TTP, because of the neurological manifestations, you can also have visual impairments. Yeah, and then both of them present with, you'll find schistocytes in the blood once you do the PBF, peripheral blood film. For HUS, self-limiting, but when need be, you can do a renal dialysis because, as we've said, the toxin can really break down the liver. So the kidneys, the kidneys will not really be able to be functioning very well. So if need be, you can do a dialysis and give a blood transfusion because of the increased loss of blood due in the bloody diarrhea. Then for TTP, you can do a plasma replacement. So the other condition, the previous ones were conditions that lead to thrombocytopenia. And we saw some of the causes of thrombocytopenia that are not disease related. Then we've seen the ones that are disease related. So the other problem can be thrombocytosis. So this is the opposite of thrombocytopenia. It is an increased count of platelets. So it's platelet count greater than 450. So the cause of the increased platelet count can be primary or secondary. So for primary thrombocytosis, it can be seen in myeloproliferative disorders, where now this is now in the bone marrow. If the patient has like a leukemia of some kind, and the bone marrow is just releasing immature blood cells of all kinds, including our platelets. So the platelets are immature, they have no function, they're not able to function well. So the platelet counts are high, but they're not really functioning. So they have no effect. So of all the myeloproliferative disorders, essential thrombocythemia has the highest platelet value, at times exceeding 1 million platelets. So thrombocythemia can lead to platelet values of over 1 million. So the primary causes are involved with the bone marrow, the formation of the platelets. Secondary causes, on the other hand, they can include acute and chronic blood loss, chronic inflammatory diseases, post-splenectomy, and iron deficiency, anemia. So for these ones, the platelet function is normal, but there is an increase in the platelet number. But in severe iron deficiency anemia, the platelet count may increase up to 2 million due to marrow stimulation. Because of the reduction of the formation of the red blood cells, so the bone marrow shifts to the formation of the other kinds of cells like platelets. So that can lead to formation of more platelets than is actually needed, leading to thrombocytosis. So those were like acute and chronic diseases, but some of these diseases of platelets can be inherited. So most of these are rare, except von Willebrand's disease, we'll see. So you can have disorders of adhesion, like von Willebrand's disease. So we remember von Willebrand's factor is involved as a glue during the formation of just the initiation of haemostasis. So it's the most prevalent bleeding disorder. It is an autosomal dominant disorder where patients present with things like easy bruising, heavy menses, excessive bleeding after some procedures like tooth extractions. And it is more common in patients with people with blood type O. So people with blood type O are more prone to getting von Willebrand's disease. Largely underdiagnosed. So the basic pathophysiology is a qualitative or quantitative defect in the von Willebrand factor. So whether it can be a reduction in the von Willebrand factor, or the von Willebrand factor is there, but it is not functioning as it should. Maybe it wasn't made normally, so it's not able to exert its effect. So we talked about von Willebrand factor. It's a large multimeric glycoprotein that is usually cleaved down into smaller pieces. Let me call them pieces, not large multimers. It is cleaved. We saw that previously. So it is this protein is coded for by chromosome 12, carried into circulation by factor 8. This is just a lot of theory. So we know its function. It serves as a intermediary for platelet adhesion. So without fully functioning von Willebrand factor, platelet adhesion is impaired. So when platelet adhesion is impaired, hemostasis is not going to be achieved. So the patient will just keep on bleeding. So treatment is usually tailored to the particular type of or subtype of von Willebrand. So the products that are available for treatment include desmopressin, which is abbreviated DDAVP. This one causes the release of endothelial von Willebrand factor. So this one, that tells you that it is for treatment of quantitative disorder, a quantitative disorder of von Willebrand factor. Yeah, BDAVP is the major drug for treatment of von Willebrand disease. Let me see if I can find, I think I saw something else. The next condition that is also inherited is Bernard-Soulier syndrome. This is an autosomal recessive disease due to mutations in the GPLB gene, so that this causes the platelets formed to be larger than normal. The platelets being larger than normal, they have defective binding to the von Willebrand factor, so they don't really adhere very well. And so the lack of adherence, of course, will lead to a lot of bleeding. So these are just like inherited diseases. We have Glanzmann's thrombasthenia, also due to mutations for genes that are involved in platelet formation, GP2B or GP3A. So we've seen conditions that lead to either decrease or increase of platelet count. You can also have platelet release defects. So once platelets adhere to an injured surface, the contents of the platelets are usually released. Besides this, it releases things like calcium that activate various factors of the coagulation cascade. It releases the vasoconstrictors. So these are some of those conditions that lead to these problems with platelet dysfunction. So with that, I think we've covered the problems that are involved with platelets. Let me just see if there are more. So maybe I can just talk briefly about thrombosis. But anyway, thrombosis is just obstruction to blood flow. So of course, once blood flow is obstructed, there can be problems like ischemia, which can lead to necrosis, the death of the tissues. And then the problem with this is that the thrombus can detach. And once the thrombus has detached, it can migrate to parts of the body that can be very dangerous. For example, if it gets to the heart, it can affect the heart. It can migrate to the brain and cause a stroke by obstructing the tiny capillaries in the brain. So arterial thrombosis can have arterial thrombosis or venous thrombosis. So we start with venous thrombosis. So there's this thing called virtuous triad. Virtuous triad are the things that are involved in the thrombus formation, and there are three. These ones we need to shika, they're important. So the first one is the slowing down of blood or hemostasis. Then the second one is hypercoagulability of blood. And the third one is vessel wall damage. So those are the three components of virtuous triad. So it's just a discussion of virtuous triad. So hemostasis leads to formation of diseases like DVT, deep venous thrombosis, pulmonary embolus. This is now when the thrombi detaches and migrates to like the lungs, something like stroke. Yeah. So it's potentially serious, and it requires to be treated like as soon as possible. DVT is genetically linked, like you have close relatives who have developed DVT in their past, you're also at risk of developing DVT. This is just a lot of wording. I don't think this is very important. Let me just go back to this summary, gives a nice summary. Yeah, this is what we're talking about, pulmonary embolism. You can also have arterial thrombosis. Some of these ones include atherosclerotic plaque in arterial walls. So once they rupture, they can cause arterial thrombosis. Risk factors include family history. It's more common in males. If you have high levels of cholesterol, that means your vasculature is already quite narrowed because of the deposits of cholesterol. So the formation of an arterial thrombosis is quite dangerous. Diabetes, blood pressure, smoking, obesity, and age are all risk factors. And these ones are the most common causes of stroke, myocardial infarctions, just because of the blockage of the vasculature in some of these organs. We talked about venous thrombosis, mostly occurs in the lower extremities due to gravity pooling of blood. So you know, movement enables blood flow in veins due to muscular contraction. So if you're not really moving a lot, your blood is not going to get back to the heart quite easily. So you can get such conditions as DVT. So hereditary risk factors include factor 5 mutation, prothrombin variants, protein CNS deficiencies, antithrombin deficiencies. You can also have acquired hypercoagulable states, where high-dose estrogen therapy increases plasma levels of coagulation factors. So the increase in coagulation factors, of course, shifts the coagulation cascade towards coagulation. And then it also reduces antithrombin and tissue plasminogen activator. These two factors are the ones that are involved in the fibrinolysis. So that means the blood clots will not really be dissolved into the blood, so they can easily detach and cause the problems that we're talking about. Major surgery or trauma also increases the risk for hypercoagulability because now the wound is quite large. So the fibrin deposit is also quite large. That's why patients who are in hospital are given drugs like enoxaparin or heparin to just reduce to help break down the fibrin and avoid clotting. Pregnancy is also another risk factor. Sepsis, heparin-induced thrombocytopenia. So some people who are on heparin usually develop antibodies to their own platelets. And then heart failure, stroke, all these conditions that can cause blood stasis, the blood not to move at a velocity at which it is supposed to. So meaning the blood will pool, the pooling of blood will cause the platelets to start adhering to each other. Yeah. This is just photos of DVT. Patients present with a lot of edema. So to evaluate thrombosis, the tests you can do are blood count, prothrombin time, same tests. PT and APTT are important. You need to check for them. Yeah. Yeah, virtuous triad. So abnormal blood flow or blood stasis, endothelial injury, and hypercoagulability of blood. Okay, this is just another summary. So anticoagulant drugs, there are two. They can be injectables or oral ones. The oral one is warfarin. We know it, coumadin. And it is a vitamin K antagonist that decreases factors 2, 7, 9, and 10. It is highly pathogenic, so patients on warfarin need to be quite careful. And then the other one is heparin. The standard heparin, there's a low molecular weight heparin. So standard heparin has a rapid action, but low molecular weight heparin has slower action. And standard heparin can be monitored by APTT, but low molecular weight heparin, you cannot monitor by APTT. You remember APTT was selected for the extrinsic pathway. Was it extrinsic or intrinsic? Extrinsic.
Intrinsic. I'm not sure. I'm not sure. I thought PT was extrinsic, then APTT was
Or
intrinsic.
it's intrinsic. APTT
Okay.
intrinsic, extrinsic.
PT extrinsic. Yeah. Okay.
Can have fibrinolytic drugs. Example, let me see. These are the notes. Fibrinolytic drugs examples include streptokinase, urokinase, the ones called reteplase, tenecteplase. So those ones are fibrinolytic drugs that they degrade the thrombi and just try to dissolve it so that it does not cause any blockage at any part of the body. And then antiplatelets, we have our aspirin. We know we've given this a lot, like to patients who have, especially as you approach older age, it's important to be taking aspirin every once in a while. It reduces thromboxane A2 production, that reduces platelet aggregation. So this is just explanations for some of the deficiencies that can lead to thrombotic disorders. You guys will look them up. We didn't talk about hemophilia. So hemophilia, we can have hemophilia A or hemophilia B. Let me see which notes are good to use for hemophilia. Um, um, this is another book I've been using. I'll also share it on the group. And I hope you guys can see it.
Yeah. No.
Okay. So another coagulation disorder is hemophilia A or B, or just hemophilia. So it can be, there are a few different types. Hemophilia A is a sex-linked disorder due to deficiency of factor 8. So hemophilia is factor 8. More common in males, sex-linked traits in males. It is linked to the X chromosome. So X chromosome, and then it's a deficiency of factor 8. So patients present with excessive bleeding. Yeah, I can just figure out the clinical picture will just be related to the level of bleeding. Clotting time is prolonged. And females can be carriers. So the females don't usually get it. So they're usually carriers. It's important to do your prenatal diagnosis for hemophilia. So the treatment involves supplementation of factor 8. And then for hemophilia B, you need to supplement factor 10. I didn't see hemophilia B. Where is it? No, it's down here. And have hemophilia B, Also X-linked, but it's recessive. Um, factor 9. So it's a deficiency of factor 9. It is less common and it's less severe than hemophilia A. And then you can also have hemophilia C for factor 11, also autosomal recessive, but this one is not sex-linked. So hemophilia C is the one that is not sex-linked. A and B are sex-linked, but C is not sex-linked. And then hemophilia A is factor 8, B factor 9, C factor 11. So treatment basically involves just to supplement these factors. So these factors are usually available, are quite expensive, but manufactured by recombinant techniques to get them, and then you now supplement these factors by introducing them to the patient. But I've seen even desmopressin can also be used. You can see here, desmopressin can also be used as an alternative to help increase factor 8 in patients who have a mild form of hemophilia A. Now the rest I think we've talked about. I think we're done with hematology. Oh, vitamin K is important for just put it here. Vitamin K is important for the manufacture of platelets and also for some of these clotting factors. So any condition that affects the body's ability to absorb vitamin K can cause problems in clotting. Vitamin K is a fat-soluble vitamin. You remember the fat-soluble vitamins are there A, D, E, and K. So any condition that affects the body's ability to also like metabolize fat, like biliary obstructions, the cholecystokinins are the ones that break down fat and enable fatty components to be absorbed. So biliary obstruction can also lead to reduction of vitamin K in the body. So that can also lead to clotting problems. GI sterilization can also lead to reduction of the body's ability to absorb vitamin K. Of course, we mentioned this liver disease. The liver is important for the production of these factors of clotting. Yeah, we mentioned all this. So yeah, we've talked about all of these ones. So you guys can use both of these books to this other one is a bit more detailed than the other one. So you can use whichever you want to use to remind yourself of these things. Yeah, we've talked about all of these things, but this one has questions. I don't think these ones are really like. Do you feel like you need to know the names of these factors?
No, I don't know. Just maybe prothrombin is factor 2. Apart from that, I don't
Yeah,
think so.
you can answer number 2. So traditional intrinsic coagulation pathway includes
So you can say D is out, anything 7 is out.
12, 11, 9, 8. The answer is B.
Yeah. I also go with B. Because factor 10 is in both
Yeah,
pathways.
yeah. Factor
So
10 is in
yeah,
both part.
yeah,
It's
yeah.
in the common pathway. It's the
Yeah, it's a common
pathway.
pathway. So yeah, B by eliminator.
So the intrinsic pathway is just the countdown from 12, 11, 9, 8. And then the extrinsic one is just factor 7. Um, Folks wonder, you know what epistaxis is? Okay, the rest I think we'll just, like, for the sake of time, do we manage to pass through clinical chemistry? You can just go through all the other necessary details slowly at your own time. But it's not really a lot. We've covered the basics, the stuff that we need to know. So the rest, the other details, you can just read slowly. So we take a break, we figure out how we're going to do this click. Is Sano in the group? I don't think Sano.
Sijamuona.
Ni sawa, acha nione nitaweza basi kuangalia hii clinical chemistry. Let me look at the. You've sent the nini to me.
Yeah.
We can meet at like 9:05. Haya, tuendelee na hii clinical chemistry. Assignment tumia some summary tulifanya na Msalu. It's basically like the same thing, but this one is quite short and vizuri. Just clinical chemistry, it's just involved with how you interpret your lab tests and be able to decipher them. So, ndio uweze kuelewa what exactly is the problem based on the results. So let me just share this document. I hope it's visible. So we all know what lab tests are and why they're important. So a positive result means the substance or condition being tested for was found. Negative means it wasn't found. Inconclusive means that it's not clear whether it's positive or negative. So reference values for different places vary because of the population in those places. What's normal in one place is not what's normal in another place. So the place you're in, the agreed reference ranges for all the labs in that area usually is quite similar. So first thing we're going to look at is a urinalysis. So for urinalysis, the things that are looked at include the color, clarity, pH, specific gravity, glucose, ketones, nitrites, leukocyte esterase, the presence of all these things. We'll see the significances. We also have bilirubin, urobilirubin, blood, protein, red blood cells, white blood cells, bacteria, yeast. So specific gravity is an assessment for hydration. It assesses how well the kidneys are able to concentrate urine. Some of these things like the nitrites are markers for bacteria. So that there are bacteria that produce nitrites, and if you have a UTI or something like nephritis, some of these bacteria will produce the nitrites and then they will appear in the urine, and you can tell that this patient has the said bacteria. Leukocyte esterase is a marker for white blood cells. Yeah, so you can just start with the first thing. So the color. So if it's red, of course, it means blood. So blood can be a sign of a UTI that has really affected your either urethra, ureter, just anywhere on the tract. Nephrolithiasis or hemoglobinuria. Green urine indicates a UTI. And then the next one was the pH. pH can be alkaline or acidic. Alkaline is associated with calcium oxalate or calcium phosphate, calculi, kidney stones. So alkaline urine is a risk factor for indicating kidney stones. Acidic urine is for uric acid, calculi, or cystine calculi. So for patients with UTI due to urea splitting organisms like Proteus mirabilis, or just one of the Proteus species, or Klebsiella, they will also show alkaline urine. Specific gravity, this one we mentioned, just how the kidneys are able to dilute the urine. So low specific gravity means your urine is very dilute. High means it is very concentrated. And it can be due to the presence of high amounts of proteins or keto acids. Glucose is indicative of maybe diabetes mellitus, but glucosuria can also be observed in pregnancy. What else? Just how to test. Ketones also for diabetes mellitus. Ketones are products of fat metabolism. So they means that when someone's diabetes is uncontrolled, they're not metabolizing their glucose, so they're living off of their fat. So you find that they will have high levels of ketones, but some ketones can also be observed in urine under what you can call normal situations, where if someone has done severe exercise, so they've burnt a lot of fat, so they can also show ketones in their diet, in their urine diets. So if someone is starving, people who they do these intermittent fasting things, you're not providing your body with glucose, so the body starts breaking down the glucose deposits. Once it depletes, goes to now the fats, so of course the ketones will show. Nitrites, some bacteria are able to produce nitrites, such as E. coli, Klebsiella, Proteus, Enterobacter. So all of these ones will give a presence of nitrites in the urine. So you could just know that there's an infection somewhere. And it can be a good indicator of maybe the type of bacteria that this is. And these ones all look like they're gram-negative. So it just tells you. Yeah, this is just the same thing. The present absence of nitrates does not equal absence of infection, because now the gram-positive ones like staph, they're not really able to produce nitrites, but they can still infect you. Leukocyte esterase, so it's an indicator of the white blood cells. White blood cells usually contain this enzyme, which is released when white blood cells die. So normally too few white blood cells are present in urine for the test to be positive. But when the number of white blood cells in the urine increases, the result becomes positive. So this is usually indicative of a UTI. Bilirubin should not be present in the urine, but when it's present, it can be an indicator of obstructive conditions in the liver or the gallbladder, hepatobiliary system. Something like hepatitis can lead to increased levels of bilirubin, which means that the bilirubin will be present in the urine. Proteins also should not be in the urine, like in large quantities. So albumin is what is used to detect proteins in the urine. So the dipstick, the urinalysis is done using a dipstick. So if it shows a positive result for proteins, it means there's albumin in the urine. Red blood cells. So this just confirms your diagnosis for maybe a UTI. There's something there's inflammation, there's an injury. So there's blood in the urine. White blood cells, we talked about this. Can also show bacteria, the presence of bacteria in the urine, meaning have an infection, a UTI. Yeast cells also can be found maybe during the collection of the specimen, there was contamination, but it still shows that there's Candida albicans. So it can be an indicator for a yeast infection. So these are just some sample urinalysis results. Like for this one, the urine appears cloudy. The urine is yellow. So this one is a bit high. So the urine is concentrated. There are nitrites, there's leukocyte esterase, there are white blood cells. So that indicates there's a UTI. These ones, you can just look at them and just try to interpret them based on the readings. The next test is a CBC. So it can be done with or without a differential. A differential just means that you go deep into the analysis of the individual types of cells. So it can detect conditions like anemia, infections, clotting problems, blood cancers, yeah, and also immune system disorders. You know, deficiency of RBCs can be due to hemolytic anemia. It can happen if someone has overbled. Conditions like hereditary spherocytosis. We saw this one where the red blood cells do not have the classic is it biconvex or biconcave? They're deep in the middle, so they look like spheres. So all these things can show in your CBC. When the RBC count is high, it can mean that there's higher than normal levels of the red blood cells, maybe due to polycythemia. We talked about these ones. There's primary polycythemia and secondary. So primary is maybe due to overproduction of red blood cells by the bone marrow due to a mutation or a biological factor in the body, or secondary due to reduction in the amount of oxygen reaching the body tissues. Maybe you've gone mountain climbing, or you're a smoker. Yeah, so your oxygen carrying capacity will try to be increased by your body, so they will make more red blood cells. So these are just the normal references. RBCs for males is between 4.3 to 5.9. For females is 3.5 to 5 times 10 to the power 6. These ones, you just read them. Hematocrit, we talked about what hematocrit is. The percentage of sedimented red blood cells compared to that of the total sample. Okay, we talked about these ones, Jana, MCH, ESR. Okay. Reticulocytes are like young red blood cells. So they indicate that the body is in an active process of producing red blood cells. So there's a normal value of between 0.5 to 1.5. But if the value is higher than this, it means the body is really trying to make a lot of red blood cells. Hemoglobin, normal value for males is 14 to 18. For females is 12 to 16. When you're analyzing your red blood cells, we talked about these ones. You assess the size and the pigmentation, sickle cell anemia, all this we talked about, Jana. White blood cells, so leukopenia is decrease, neutropenia is for neutrophils, decrease in neutrophils, basopenia for basophils, lymphocytopenia for lymphocytes, monocytes, same thing. Penia means decrease. The unit, the normal values are here, 4,000 to 11,000 for all of these ones. You'll read. So a low white cell count may be due to an acute viral infection or due to chemotherapy, radiation, plastic anemia, all things that affect the bone marrow. Its ability to make cells can lead to leukopenia. HIV, we talked about this. It's a threat to white cells. Other causes include these autoimmune conditions like systemic lupus erythematosus and Hodgkin's lymphoma. Cancer, typhoid, malaria, all these ones can cause leukopenia. Neutropenia is decreased production of neutrophils. Can be due to aplastic anemia, heavy metal poisoning, arsenic poisoning, B12 deficiency, radiation, hereditary disorders, or it can be because the neutrophils are being actively destroyed, maybe due to an autoimmune process, or maybe chemotherapy. Some of these drugs cause neutropenia. Lymphocytopenia is now for lymphocytes, can be caused by autoimmune disorders, infections, bone marrow damage, corticosteroids. We know steroids are implicated a lot in the reduction of the body's immunity. Low monocytes just indicate that there's bone marrow damage or failure or hairy cell leukemia. For this one, you need to do repeat tests. Eosinophils, they're normally low, so this one is not very significant. Also basophils. Now, the opposite of tinea is cytosis. So leukocytosis is increase in the total number of white blood cells. And then you can have all the others. Neutrophilic leukocytosis or basophilia or eosinophilia. Leukocytosis usually means there's an infection in your body, commonly bacterial or viral, and your body is actively making more cells to go and fight the infection. It can also mean leukemia, especially if the values are overly high. So that can just point to bone marrow problems, allergies, asthma, tissue death, intense exercise, or severe stress. This is just a repeat. Lymphocytes are a bit more specific for viral infections, and neutrophils are a bit more specific for bacterial ones. But lymphocytes can also go high for certain bacterial infections like pertussis, which is whooping cough, or even TB. Toxoplasmosis is another condition, chronic inflammatory disorders, stress. Monocytosis monocytes are going to increase with chronic infections like TB, fungal infections, infections within the heart, collagen vascular diseases like lupus, arthritis, vasculitis. So eosinophils are now for allergies and allergic conditions. So basophils is mostly bacterial. Lymphocytes is mostly viral. Monocytes, chronic infections. Eosinophils for allergic conditions mostly, or parasitic ones. So cancers are all of these things that cause increases. If you have cancer, cancer will increase, especially leukemias. They will increase the values for most of these cells. And to differentiate, it's not usually small increments. For cancer, it's usually very high increments in the values. Basophilia also for allergic reactions and inflammation. So eosinophils and basophils are highly indicative of allergic reactions or inflammations. We've talked about platelets, so I don't think I'll go into it again. Talked about PT. Things we've talked about. So CBC with differential just means you've done all of these individual cells, especially for the white blood cells. And these are just sample results that you can try to interpret. So when it comes to test for the cardiovascular system, some of the markers, the cardiac markers include troponin. So when muscles of the heart are injured, troponin leaks out, and then its level in the blood rises. So there are two types of troponin. There's cardiac troponin T and troponin I. The I is more of a specific marker for cardiac injury. So they are the most specific, especially troponin I. So it's the most preferred for confirmation of a cardiac event. So elevations of troponin can also lead to the diagnosis of other conditions, especially troponin T. So it can help you determine whether it's myocarditis, pericarditis, cardiac trauma, endocarditis, pulmonary embolism, stroke. So unless you identify that it's troponin I, which is now more specific for cardiac event, T can also be indicative of all these other conditions. Another marker is creatine kinase. It is usually found in mitochondria and cytoplasm of skeletal muscles, cardiac muscles, the brain, and other tissues. So this one is not as specific as the troponins. You can see it's found in other organs apart from the heart. So it is also used for the diagnosis of acute MI, and elevated levels of creatine kinase are used to diagnose myocardial infarction. CKMB. Guys, what is CKMB? Committee. Marco job. Yeah, so CKMB, I'm seeing it's creatine kinase of the myocardial band. And it's makes up 5-7% of creatine kinase in skeletal muscle. So it can interfere with your values. As this is just an indicator that it is not a very selective result. The other marker is BNP, brain type natriuretic peptide. So this one is for diagnosis of heart failure. The normal values are less than 100 picograms per ml. Critical value for BNP is over 400 picograms per ml. That means heart failure is likely. But BNP can also be increased by other conditions like acute renal failure or chronic renal failure, hypertension, other pulmonary diseases, myocardial infarction. So it's also not a very sensitive marker. So the most sensitive is the troponin, especially troponin I. Total cholesterol is a lipid profile. So the parameters checked are LDL, HDL, triglycerides. So we know LDL is what is usually known as bad cholesterol. HDL is known as good cholesterol. These are just terminologies that help you know how dense it is in terms of lipids, the lipids to protein ratio. So more protein is good, more lipid is bad. HDL, so HDL is good cholesterol because it contains more of protein and less of lipids. So the higher the better. And then the opposite is true for LDL, the lower the better. But they all have their functions, so they all have their normal reference values. Then you can also have our triglycerides. These are just indicators of what's your fat level to increase, to show you whether you are at risk for developing atherosclerosis, which can now also lead to conditions like myocardial infarction because of reduced blood flow to the heart. Yeah, so it includes total cholesterol level, LDL, HDL, and triglycerides. So liver tests, it measures the enzymes that are produced by the liver. So the parameters include ALT, alanine transaminase. So ALT is an enzyme that is used to metabolize proteins. The liver is damaged or is not functioning properly, ALT is released into the blood. So a high result of this can be a sign of liver damage. The next enzyme is AST, aspartate transaminase. So it is an enzyme found in several parts of our body. AST is found in several parts. AST levels are not specific for liver damage. You have to, it's combined, it's a profile. You test for all these enzymes together. You can't test for just one enzyme unless you're doing a confirmatory test. So when the liver is damaged, AST is released in the bloodstream. So high levels indicate liver problems, but AST is not specific because it's found in other parts of the body. So both AST and ALT are sensitive indicators of liver cell injury, and they can help you come to diagnosing diseases like hepatitis. Yeah, as we've seen, AST is also found in other parts of the body like the heart, the skeletal muscles, so it's not specific. So ALT is what is a specific indicator. Acute liver failure is marked by elevations in AST and ALT over 15 times the upper limit of normal. And then it is also marked by hepatic encephalopathy, as well as a prolonged thrombin time, PT. You can already know why we just talked about this in the previous session. It's because the liver is the one that makes the clotting factors. So hepatic encephalopathy, yeah. Hepatic encephalopathy is one that is due to high, is it ammonia? We'll just read up. Another parameter in the liver function test is bilirubin. So bilirubin is a waste product processed by the liver. We saw bilirubin is a product of red cell death. So a damaged liver cannot process bilirubin as it's supposed to. So a high result on the bilirubin test indicates that the liver is not functioning well. The normal value is 0.2 to 1 milligram per deciliter blood. So bilirubin is of two types. There's unconjugated and conjugated. And bilirubin is what is responsible for the development of jaundice, yellowing of the skin. So depending on whether the bilirubin that he's accumulating is conjugated or unconjugated, we can have prehepatic jaundice. This is caused by increased hemolysis. So this one results in the increased presence of unconjugated bilirubin in the blood, as the liver is unable to conjugate it at the same rate. So it means that conjugated unconjugated bilirubin means that the liver has not had a chance to conjugate this bilirubin. So the problem is not per se in the liver, it is before the bilirubin reaches the liver. So it is, it's safe to diagnose that it can be due to hemolysis, the death of the red blood cells. So stuff like malaria, sickle cell disease, all these diseases that cause hemolysis will show high levels of unconjugated bilirubin. And then hepatic jaundice, this is liver impairment. So the liver is not able to conjugate bilirubin well. So there will be both conjugated and unconjugated bilirubin in high amounts than normal. And this one is due to just liver damage, conditions that affect the liver, hepatitis, hepatotoxic drugs like Panadol overdose, alcohol abuse, and then post-hepatic jaundice. So the liver is functioning as it should, but the bile is not being released, like the product of the conjugated bilirubin is not being released. So it accumulates, goes back to the blood because of the blockage of the bile ducts. So you will find high levels of conjugated bilirubin. So that tells you that the problem is not really in the blood or in the liver, it's due to blockage. So the things that can cause obstruction are like gallstones. You can have hepatic tumors where the tumor grows large enough to block the ducts. Pancreatic tumors, from our anatomy, how close the pancreas is, it's actually like kind of intertwined with the liver and the gallbladder. So a pancreatic tumor can also grow large enough to block the bile ducts. Other parameters are ammonia, blood ammonia. Ammonia is usually detoxified in the liver. So high ammonia levels indicate that there's liver damage. Serum albumin. The liver is what manufactures the blood proteins like albumin. So all these values, when they deviate from normal, they indicate that there's an active disease process. Prothrombin time because of the clotting factors. Yeah. So when you're trying to diagnose something like alcoholic liver disease, you use the AST-ALT ratio. And the reference range is that it should be less than 1. In alcoholic hepatitis, AST is increased more than ALT. So the ratio becomes greater than 2. So in alcoholic hepatitis, AST is increased more than ALT. This is due to release of AST from mitochondria. You remember, AST is the one that is found in other parts of the body. So it's going to be released more than ALT because ALT is now mostly predominantly in the liver. So that imbalance leads to increasing of the ratio that now becomes suggestive for alcoholic hepatitis. If the GGT, gamma glutamate level, is also elevated, this now strongly suggests the diagnosis of alcohol abuse. GGT is also a very good indicator of obstruction in the duct, either the bile ducts or somewhere just along the ducts that move bile. It's also, as you've seen, a marker for alcohol abuse and alcoholic liver disease. So if a patient presents with jaundice and quite high levels of GGT and they are not alcoholics, they claim to have no history of alcoholism, you can just try to rule out that most probably they might have an obstruction, like a gallstone or something. Then the other parameter is alkaline phosphatase, ALP. So this one is increased in cases of cholestasis. hepatic carcinoma, and biliary tract obstruction. So this is another one that will also help you identify that maybe this patient has a gallstone or something. So ALP is present in bone, liver, intestines, and placenta. So in the absence of bone disease or pregnancy, ALP elevation indicates cholestasis. So if ALP is high alone, but GGT is not high, those are signs that there might not be obstruction. A person might have other diseases like bone disease or pregnancy. But if both are high, it's a clear indicator that there's obstruction, maybe in the bile ducts. So this is just a summary plus the reference values. So these case studies. So we now go to the kidney function tests. So we have tests for glomerular function, tests for tubular function, and urine examination. We've done the urine examination. It was the first one we did, the urinalysis. So one of the tests is the blood urea nitrogen tests. It measures the amount of nitrogen contained in the urea. So if this is high, it means the kidney is not functioning as it should. But the UN is also affected by protein intake and liver function. So the test is done together with a blood creatinine, which now creatinine is a more specific indicator of kidney function. Yeah, so it's the same thing. Urea is affected by protein intake. If you're dehydrated, your urea is also going to be quite high. Muscle breakdown can also increase urea levels. Yeah. Total protein and albumin. So both serum total protein and albumin is decreased in chronic kidney disease due to increased proteinuria. So yeah, in chronic kidney disease, the kidneys are more highly permeable than they usually are. So they allow the passage of products that are usually kept within check. So there will be loss of more protein than usual. And then that means total protein will be decreased when you do a blood test. Electrolytes. So sodium, you look at sodium, potassium, chloride, and calcium. So you know the terminologies for all of these ones, like sodium is hyponatremia or hypernatremia. So in CKD, there's hyponatremia and hyperkalemia because the kidneys reabsorb sodium in the exchange for potassium. Then in CKD, chloride and phosphates are increased and calcium is decreased due to deficiency of vitamin D. Vitamin D production is done by the kidneys. So if the kidneys are not functioning well because of the chronic disease, so calcium will be decreased. Okay, this one's mentioned, RBC count, urine examination, proteinuria, what about this one? So this is the formula for estimating creatinine clearance. So it's different for males and for females. So I think this was an error. Is it the second one is the one for males? I think this second one. Let me just confirm. I'll confirm this one and just share it. So these are the lab tests and their results, the normal values. So reduction of sodium levels, hyponatremia, is caused by excess water, e.g. Serum antidiuretic hormone. So for this one, you restrict water so that the sodium level is increased. Sodium levels increase in severe dehydration because the what's it called, plasma volume contracts, so the value will go high. Diabetes insipidus, this leads to loss of water. So of course, using the same rationale, the plasma volume contracts, meaning the sodium value will be perceived to be high. Potassium levels increase with renal dysfunction. Acidosis, if someone is taking potassium sparing diuretics, of course, they will increase, something like spironolactone. Hemolysis, potassium is mostly an intracellular ion. So if there is a lot of cell destruction, like in hemolysis, burns, like just injuries that damage cells to release their intracellular components, the potassium value will go high. And once it goes high, potassium is usually it has a narrow margin for allowing change. So it's quite dangerous because it affects the heart. Potassium levels are decreased by diuretics or alkaloids, or in severe vomiting and diarrhea. All these things can cause reduction in potassium levels. Calcium levels are increased in hyperparathyroidism, Jet disease, bone tumors due to bone destruction, decreased neuromuscular activity. Then they decrease with dietary deficiency, increased excretion, pancreatitis, hypoparathyroidism, rickets, osteomalacia, and renal insufficiency. These are now other ions, chloride, phosphorus. And they are now the normal values. So this one will be quite important to know. So in renal failure, the ions and the indicators that are increased are potassium, urea, creatinine, hydrogen, phosphate, and magnesium. Okay, potassium, urea, creatinine, hydrogen, phosphate, and magnesium. And then the decreased ones are sodium, bicarbonate, and calcium. So they're the ones that are decreased in renal failure. So when you're treating someone who has renal failure or with kidney problems, the things you use for diagnosing and also for monitoring, the important ones are potassium, urea, creatinine, and phosphate. These ones are the most best indicators for whether the patient is improving. Something like potassium, it's important to monitor because fluctuations can be deadly. Yeah. So for diabetes, this one, I think we know the values. So the normal values after blood tests for whether it's fasting is less than 100 or less than 5.6. The HbA1c value for normal patients is less than 5.6 as well. And then the OGTT, which is the oral glucose test, where you're given like 50 grams of glucose or 50 milligrams of glucose in water you drink, and then you wait like 30 minutes and they test your blood. So the value should be 7.8, below 7.8. So values for pre-diabetes are 5.6 to 6.9 for fasting. HbA1c is 5.7 to 6.4. And OGTT is 7.8 to 11. And then diabetes in an unpregnant adult is a fasting glucose of over 7 and an HbA1c of over 6.5%. Then for the oral glucose test is values of over 11.1. So the other test that is usually carried out is for the assessment of the thyroid function. We know we have TSH, 3T4. Let me see. Yeah, this one it has explanations. So TSH levels are adequate for the diagnosis of hypothyroidism and hyperthyroidism in most patients. A high TSH signifies hypothyroidism. Let me see this, whether that's these notes didn't have that cascade. Let me see if I can find it. Yeah, this one. This the diagram for the HPA axis. Where is it? Thyroid. This one. Sijui kama ni visible. This is the last thing we're doing. So we know the thyroid hormone formation is under influence of the hypothalamus and the pituitary glands. So the hypothalamus produces thyrotropin releasing hormone, which stimulates the pituitary gland to release thyroid stimulating hormone. Thyroid stimulating hormone then instructs the thyroid gland to release T4 and T3. And then the levels of T4 and T3 are the ones that provide negative feedback to the pituitary gland as well as to the hypothalamus. So high TSH signifies hypothyroidism because the levels of T3 and T4 being released are not sufficient enough to provide the feedback. So that means the thyroid is under functioning. That's why it signifies hypothyroidism. The TSH is still being released by the pituitary gland. And then low TSH signifies hyperthyroidism. Now, in the opposite way, the thyroid is overworking, so the negative feedback is also overworking to stop the pituitary gland from releasing the TSH. So normal values are like this, 0.5 to 2.5 milliunits per liter. And a TSH level of less than 10 signifies overt hypothyroidism. Yeah. Then the free T4 and T3 values, of course, will just be indicative of hyper or hypothyroidism. So what is actually the TSH is what is, it shows it's more specific for diagnosis. Yeah, I think we're done. We can call it a night. Guys, mnaonaje? Tuonane siku ingine. Mike Oxmouth. Yes. Oh my God, what did I just say? Hi, guys. Good night.
Kazi daktari.
Sawa, sawa. Thanks, guys.